Multifactorial inheritance. This is actually the most common form of inheritance. We've talked about Mendelian inheritance and other kinds of things. Multifactorial is actually by far the most common. I know we haven't talked much about chromosomes yet, but chromosomal abnormalities as far as genetic disease occurs in about 1 in 6,000 individuals at birth. And it actually goes down to 3.8 of every 1,000 when you look at the whole population. And the reason for this is many of these chromosomal abnormalities, including trisomies 13 and 18, again, we will go into detail during sex and reproduction, don't survive. So the number of chromosomal abnormalities at birth is actually higher than the general population. When we go to single gene mutations, for instance, we talked about, cystic fibrosis is a single gene mutation. When we put them all together, it's about 10 of every 1,000 at birth, but it actually doubles as far as population prevalence because there are a lot of single gene abnormalities that are not apparent at birth and actually double in time, the number when we look at the population. But then let's go to multifactorial inheritance. There's genetics, there's environment. It's kind of a combination. Greater than 50 for every 1,000 at birth and greater than 600 of every 1,000 in the population. Basically, 60% of everyone has some type of multifactorial disorder. So I just want to go over some definitions. Heritability is defined as the proportion of the total phenotypic variation in the population that's due to genetic factors. Familial aggregation of disease. Relatives share a greater portion of genes with one another than they do unrelated individuals. Like, duh, right? Therefore, they're more likely to have the same disorders than unrelated individuals. Common sense, but it has a name. Concordant for disorder means that two relatives have the same disorder, and discordant means one individual has it and the other does not. Now, one of the ways to kind of tease that out is twin studies. And twin studies have been done for hundreds of years. And unfortunately, during World War II, Mengele did some horrible twin studies. But it's actually comparing monozygotic to dizygotic twins. And it's a great way to kind of pull apart what is purely genetic and what is environmental or other factors that we don't quite understand yet. Monozygotic twins is the most extreme example of similarity of genes. In a monozygotic twins, the egg and sperm get together, and somewhere by the 16-cell stage, all of those 16 cells have the ability to create a complete individual. So identical twins separate some time before. If they separate actually before the 16-cell stage, there's 2 placentas, 2 babies, but they have the exact identical genetics. If they separate between 16 and about 32 cell stage, there's actually 2 sacs, 1 placenta, and they're identical twins. And then if they separate a little bit too late, then they're conjoined. So if there's a single, and sometimes they have a single sac, which is actually a dangerous pregnancy, but if you see a single placenta and 2 sacs, and they're the same sex, because identical twins always have to be the same sex, they're monozygotic. But they still could be monozygotic even if they have 2 separate placentas, 2 separate sacs. Again, we're going to go over more of that detail next year, but I just wanted to refer to that. But in any case, identical twins came from the same egg and same sperm. And they also always have to be the same sex. Whereas dizygotic twins are basically siblings that grew up in the same genetic environment, the same placenta, the same uterus at the same time. But they're as similar as siblings, which is about 25% of their gene pool. They can be a separate sex. One could be a boy, one could be a girl. And like I said, they're siblings that have the same birthday. So twin studies is a way to kind of tease out genetic from environmental effects. And so we look at monozygotic twins that have exactly the same genetic components compared to dizygotic that were raised in a relatively similar environment. How much is genetics? How much is environmental? Limitations? Well, monozygotic twins do not actually have exactly the same genetic expression despite the identical genotype. And genetic expression is something I learn new things every day. And what I'm telling you today might be different than what I tell people next year. But one of the examples of genetic expression includes females with X inactivation. Females are really like a mosaic. And so identical females are not probably as identical males. But anyway, whole different issue. And then the intrauterine environment may be a little bit different. For instance, one baby may have a better blood supply than another and might result in other issues. So concordance rate, the rate of a particular disorder seen among monozygotic compared to dizygotic twins. So if the concordance is 1 in monozygotic twins, then you would say it's all genetic. So let's say phenylketonuria or PKU. It's autosomal recessive. If one has it, the other has it. But let's look at these multifactorial disorders. Cleft lip and palate has a 0.38 concordance among monozygotic twins and 0.08 in dizygotic twins. So there's a genetic component, but it's not 100% genetic. So identical twins are only concordant 0.3 about 40% of the time for cleft lip and palate, that one has it and the other has it. But it's less than 10% in dizygotic. But cleft lip and palate is far less common than that. So it's more common for dizygotic twins to be concordant for cleft lip and palate than the general population. And 4 times more common with monozygotic twins. So there's some kind of genetic component, but it's certainly a lot more complicated than that. But then let's look at an infectious disease such as measles. It's 0.9. If one twin gets measles, so will the other. Whether they're monozygotic or really 0.87 dizygotic, this is an infectious disease. Basically, you and somebody sitting down next to you in class, if one of you gets measles and he hasn't been vaccinated, so will the other one. So that's less likely to do with genetics. Characteristics of complex diseases. Pairs of relatives who share disease predisposing genotypes at relevant loci are still discordant for the phenotype. So, doesn't necessarily mean you'll get it. And the disease is more common among close relatives. So there are a lot of other factors that today we don't 100% understand. Now, empiric risk is something people use a lot when we're talking about this, and this is the risk of a particular disorder recurring looking at population data. So and the most important thing is that we understand empiric risk. What is the risk just because you're a human being living on the earth that you're going to develop this? For instance, we do this a lot, like with breast cancer. 1 in 9 women will develop breast cancer. Actually, now they say 1 in 8. 1 in 8 women will develop breast cancer. Again, this changes year to year. Just because you're a woman, irrespective of your genes, that's your empiric risk. And empiric risk is the lowest risk you can get down to, and genetics can just increase it from there. The other thing I want to talk about is recurrence risk with different sexes. So pyloric stenosis is a congenital obstruction at the bottom of the stomach where there's a hypertrophy of the pylorus. And the problem is then the food can't get out this way, so the kid spits up a lot. And it actually can cause a lot of issues. They can become dehydrated and failure to thrive and things like that. And this is 5 times more common to occur in males than females. An individual with this disorder in the less involved sex, such as a female, have more predisposing factors. So, what that means is the risks of a male infant to develop pyloric stenosis, if the mother or sister had pyloric stenosis, is far higher than if the father or brother had it. So, if the mother or sister had it, his risk is 9.2% versus 3.8% if it was his father or brother. So, and again, these are empiric risks. These are just, not empiric, these are recurrence risk based on looking at populations. Common human diseases that show multifactorial inheritance include retinitis pigmentosa, Hirschsprung's disease, diabetes, neural tube defects, cleft lip and palate, and congenital heart defects. So I want to talk about Hirschsprung's disease. And Hirschsprung's disease is caused by a complete absence of ganglionic cells in the mesenteric and submucosal regions of the colon. As a result of the loss of those ganglions, and again, if you remember from, when you learned about the intestinal tract, it's really peristalsis that moves the stool throughout. When you lose that electrical signal because you don't have those ganglions there, then it kind of stops. And there's an area that is not like moving things through. And as a result, this becomes kind of atretic. And everything backs up here and it becomes massive. And so they used to consider it like a megacolon proximal to the lesion. Most affected individuals present at birth because they don't pass their first stool, known as a meconium. However, they can present later in childhood with chronic constipation and abdominal distension. Hirschsprung's disease, or HSCR, occurs in about 1 in 5,000 births. And it's usually an isolated defect, but it is seen more commonly in children with Down syndrome. We're not 100% sure why that is. There's an increased risk of non-syndromic HSCR among close relatives. So non-syndromic means it's not like part of a bigger syndrome like Down syndrome. And it's more common, again, in males and females. Hirschsprung's is linked in some families to the Rett gene, which is located on the long arm of chromosome 10. But most cases don't have this. And what's kind of interesting about the Rett gene is the Rett gene, other mutations of the Rett gene can also result in an endocrine, something called multiple endocrine neoplasia, which we'll learn about next year. Anyway, the next and probably one of the most common things that we hear about multifactorial is diabetes, especially type 2. That's why I put it in this case. But there are two common forms of diabetes, type 1 and type 2. And type 1, insulin dependent, occurs in about 10% of patients and usually has a childhood onset. Type 2, which they used to call non-insulin dependent diabetes, they don't really use that as much anymore, occurs in 88% of patients. So it's far more common than type 1. So almost 90% of cases of diabetes, if you just use the word diabetes, you're probably talking about type 2 or non-insulin dependent, is more of adult onset. So type 1 is really the autoimmune destruction of the beta cells in the pancreas. So it's almost like an autoimmune. What triggers that? We're not exactly sure. Concordance among monozygotic twins, if one develops type 1 as far as the other, is about 40%. So it's more common among monozygotic twins than the general population, and dizygotic is 12%, more common among siblings than the general population. This means there is a genetic component to type 1 diabetes, but it's far more than just genetics. So there's some trigger that we don't quite understand. So the monohistocompatibility region, or MHC, is responsible for the immune reactions in the autoimmune reactions. So the DR3 and DR4 are involved in this immune response. And in family studies, siblings with the same DR haplotype are 13%, have a 13% risk of being concordant for diabetes. So this is just, it's more our beginning of understanding what's going on here. So let's talk about type 2 diabetes. So type 2 diabetes is a completely different disorder. And again, we used to refer to it as non-insulin diabetes, and it usually presents during adulthood. However, as we've had more and more childhood obesity, we are seeing this in younger and younger individuals. Type 2, there's a deficiency of insulin receptors on the cell surface to bring the glucose in. So there's two receptors here. There's the insulin receptor, and then there's the glucose transporter, okay? So insulin has to attach to the insulin receptor to open up the glucose transporter to let the glucose into the cells. So when there aren't enough insulin receptors, the glucose in the bloodstream is not getting into the cell. As a result, it stays in the bloodstream and it causes a number of issues. And so the problem with type 2 diabetes, with type 1, there's a destruction of the insulin receptors, an autoimmune destruction of the insulin receptors. But in type 2, there's just not as many as there should be. So when glucose is not efficiently brought into the cell, there's not enough glucose in the cell for energy. So that's actually a problem, because even though there's tons of glucose outside, the inside is craving more glucose. When an individual has a normal blood intake of glucose, has a normal increase like intake of glucose, and there's normal blood glucose, then the decreased receptor is not really a big deal. You know, there's an appropriate amount of glucose, and the half of the amount of receptors are bringing it in, and it's not sitting out here in the bloodstream causing trouble. But when there's too much glucose in the bloodstream, this overwhelms the number of receptors. And this is known as insulin resistance. So this is actually one of my favorite slides about talking about multifactorial inheritance. And when I talk about it, type 2 diabetes is really one of my favorite examples. So you have genetic factors, and in this case, we kind of know about the insulin receptors. Maybe there's other things. And the environmental factors. Do you put too much glucose into your bloodstream? And here's being affected. So if you have genetic factors that don't have enough insulin receptors, but you eat the right amount of food and you exercise, then you have genetic factors, but you don't have your perfect BMI, you don't have environmental factors, so you don't have type 2 diabetes. But then somebody gets pregnant and they put on 100 pounds. And near the end of their pregnancy, you have some called gestational diabetes. Anybody with gestational diabetes I'm worried about. But then they take off that weight, they go back to the health club, and they breastfeed, and they lose that weight, and they move back over here. And then the opposite. It's if you've ever seen some of those shows, like how this 800-pound person sitting in the bedroom that they have to use a saw to get him out of the room. It's like, how is he still alive? How has he not died from diabetes? Well, he probably doesn't have any genetic factors. So he has tons of environmental factors, but he doesn't have genetic factors. And that's how this individual that weighs, 800 pounds doesn't have type 2 diabetes. But a lot of people have some genetic factors. And again, I would argue anyone with gestational diabetes, unfortunately, has proven that they're at risk and they have to be really careful. Another really common multifactorial disorder is called neural tube defects. And neural tube defects occur in 1 in 1,000 live births. And what it is during the development, the spinal canal does not close completely. Now, here is a very small neural tube defect at the end, and any of the nerves that come up distal to where this is don't form correctly, so they can have club feet and other kinds of anomalies. This child would have more severe issues because it's further up in the thoracic region. But here is, it didn't close in the brain, and this is called anencephaly. This is a lethal abnormality where the brain does not form, and here's different, forms of this. The higher the region, the more risk to the brain. The lower risk, the lower the region, the higher the risk, the higher the chance of survivability. But neural tube defects occur in all ethnic groups. However, there's variability. The risk in the Caucasian population is 1 in 1,000. The risk in the Hispanic population was 1 in 400. However, once a baby has been born with a neural tube defect, the recurrence risk for a future baby is 1 in 100. Now, in Ireland, the risk of neural tube defects was like 1 in 100, but then if they moved to the U.S., it went to 1 in 1,000. And this actually was initially, this is where they came up with this, like, what what changed, you know, and what changes probably their diet is the amount of protein they would eat in their diet. And so, whereas in the Hispanics, that doesn't seem to happen. Maybe their diet just hasn't occurred, you know, dropped as much or changed as much. So this actually came to the realization that folic acid, which is seen in meat and proteins, is involved in a number of pathways in neurulation and formation of the neural tube. And folic acid supplementation in foods has decreased neural tube defects worldwide. But it's really important because the neural tube closes at around the time you find out you're pregnant, about 4 to 8 weeks gestation. So it's important that somebody's on prenatal vitamins very early in the pregnancy. So the risk of having a second child with a neural tube defect can be decreased by tenfold by putting the mother on high-dose folic acid for 3 months prior to the time that she becomes pregnant. So this is actually, you know, something we can do medically. And so I usually, whenever I'm talking to somebody, you know, start your prenatal vitamins the minute you stop taking birth control. It's a little teeny pill. You know, people tell me all the time, oh, I didn't take my prenatal vitamins the first trimester because I was sick. The first trimester, the prenatal vitamins are for the baby. The next 2 trimesters, the prenatal vitamins are really for the mom. It's calcium, it's iron for your blood, because once the baby takes hold, it's more like a parasite. So, but the first trimester is when these, you know, when the folic acid, and if you can't take a prenatal vitamin, take the little teeny folic acid, because that is really can make a huge difference. There is also some studies that show it might even decrease congenital heart defects, which is dovetails into the next thing I'm going to talk about, which is congenital heart defects. These occur in about 8 of every 1,000 live births, and it can be part of a syndrome or it can be isolated. For instance, 50% of babies with Down syndrome have a congenital heart defect. Although if a baby had Down syndrome and, for instance, a ventricular septal defect or some other kind of congenital heart defect, I would not be worried about the next baby that did not have Down syndrome to have a congenital heart defect. However, if a baby without a syndromic cause of congenital heart defect, then I would be at higher risk. So the population risk of a ventricular septal defect or VSD is 0.17. However, the risk of siblings is 4.3, with a relative risk of siblings 25% increase. Patent ductus, this is a ductus in between the 2 sides of the heart to shunt blood away from the heart during embryonic development. It's very rare in the population, 3.2 in siblings, or 38% relative risk. And ASD between the 2 sides of the heart, population incidence very uncommon, 3.2 in siblings, 58%, and aortic stenosis is really one of the highest, 0.044 with frequency in siblings at 2.6 or 59% relative risk. So if, for instance, if a baby was non-syndromic that had a congenital heart defect, we usually recommend fetal echo in the next sibling to make sure if they did have a congenital heart defect, we would have them delivered in the right place. So I promised to show you about a little bit more about cleft lip and palate. 1 in 1,000 babies are born with a cleft lip and palate, plus or minus palate. And here is a baby before and after repair. And the reason I like to show this picture is when I'm counseling families, doing genetic counseling, especially if it was a man and he grew a mustache, I may not know. They do such an outstanding job of repairing cleft lip and palates, you may not even recognize that they had it, and yet the risk might be increased. So the incidence in the Asian American population, about 2 in 1,000 live births, and the incidence in the African American population is 0.41. So it's, 1 in 1,000 in the Caucasian population, double that in the Asian American, and half of that in the African American. Every ethnic group is at risk of higher risk for some things, lower risk for other things. And so when I'm doing genetic counseling, it's not as important for you to memorize these numbers. Do not memorize these numbers, but just know that every population is at a higher risk of some things than others. So cleft lip and palate is usually, as I said, inherited in a multifactorial fashion. There are a number of other syndromes that can be associated with cleft lip and palate. We're going to talk about more of those syndromes later. But when it's so one of the things I usually tell, especially the peds resident, is if you have a 7-pound baby who has a cleft lip and palate and otherwise looks great, it's probably just an isolated cleft lip and palate. If you have a full-term baby that weighs 4 pounds and has a cleft lip and palate and, is microcephalic, then I'm more worried it's part of a bigger picture. The other thing I do, and I just going to go back to this picture again, is I'll draw a line here and look at the baby. How does the baby, are the ears appropriate? Are, the eye spacing they're usually a little hyperthaluric. How big is the jaw? Do they have extra fingers or toes or other kinds of things? So I usually try to ignore this cleft lip and palate because when people look at it, they're like, oh my God, but really there's a lot more to look at. Teratogens can increase the risk of cleft lip and palate. Again, we're going to talk about that more next year. And families with syndromic causes of cleft lip and palate may have an increase, non-syndromic causes of cleft lip and palate may be at higher risk of having another baby with cleft lip and palate over the general population. Whereas if it's syndromic, it all depends on what the syndrome is. 60 to 80% of babies with a cleft lip and palate are males. Isolated secondary palates are more common in females. Again, these are not as important for you to memorize. And unilateral clefts are more common than bilateral. 70% of unilateral cleft lips and 85% of bilateral cleft lips also involve the palate. So lips and palates often go together. So this is just some statistics. A baby, is born with a cleft lip and palate. Well, 1 in 1,000 babies, if it's a Caucasian baby, 0.04 palate. But what if the baby had an affected parent? Now you go to 4%. So if a couple came in and said, my friend down the block had a baby with a cleft lip and palate, what's the chance that I'll have a baby with a cleft lip and palate? I'll say 1 in 1,000. They came in to me and said, Dad had a cleft lip and palate. What's the risk that our baby will have a cleft lip and palate? It goes from 1 in 1,000 to 4%, to 4 in 100. Or if they say, Dad had a cleft lip and palate, and our first baby had a cleft lip and palate, what's the chance that this baby will have a cleft lip and palate? Now we're up to 17%. So most are sporadic, but in some families, we're getting closer and closer to Mendelian inheritance. And again, here's just the same, a mother is affected, first sibling, second sibling, by the time we get to the third, cleft palate. So the more individuals in the family with the same disorder, the closer you're getting to Mendelian inheritance. And that's all I'm trying to get to in these slides. Multifactorial with increasing individuals in the family. So we talked about neural tube defects. 1 affected child, 5% recurrence risk. 2 affected children, 10%. Pyloric stenosis, 5% with the first, 10% if you have 2 affected. And cleft palate, 3 to 4%. And then it increases again to 8 to 10% with the second affected individual. Genetic counseling in families with multifactorial traits, the recurrence risk is higher among first-degree relatives than more distant members of the family. So, when I'm taking family history, my dad's brothers, grandchild, that's a lot of lines. I'm not too worried. The best estimate for recurrence risk, again, is the empiric population risk. Recurrence risk can be increased by a lot of factors, including the affected relatives in the family, the number of affected relatives, the onset, the sex of the affected individual, and sometimes if the parents are consanguineous. So, multifactorial inheritance is the most common form of inheritance. It is a combination of inherited traits and environmental factors. And twin studies can help determine if it's purely Mendelian. So again, monozygotic twins, I would expect 100% concurrence, and dizygotic twins, 25%. If you looked at a lot of them, not just one individual in the family. Whereas multifactorial monozygotic is not going to be 100%. It's going to be maybe 40%. And dizygotic, again, when we talked about the cleft lip and palate, like 8%. So much higher than the general population, even amongst siblings, but more common with identical genes than siblings, but certainly not 100%. So that's more, multifactorial. So that concludes this lecture on multifactorial inheritance.